In our final podcast on the female reproductive system, we're going to talk about pregnancy, and then we'll say a few words about the mammary glands. Now, pregnancy interrupts the menstrual cycle. Fertilization plus implantation leads to the gravid phase. And so in the gravid phase or pregnancy, the endometrium decline is delayed until after parturition. The blastocyst will embed into the uterine mucosa around day 7 or 8. Now there's an implantation window. That's the time when the endometrium is programmed to receive the blastocyst under the influence of progesterone and estrogens. In humans, the implantation window occurs between day 6 to day 10. Now, drugs like RU486, they're anti-progesterone drugs. These compete for receptors on the endometrium, and thus the epithelium can't be programmed to receive the blastocyst. The cartoon on the left shows that there are interactions that occur between the cell surfaces of the blastocyst and the endometrium, and these cell surface interactions are necessary for implantation. So, for example, we know that the blastocysts are secreting selectins and that there are selectin receptors on the endometrial cell surfaces, and this receptor ligand interaction plays a very important role in implantation of the early embryo into the uterine wall. As you know, cells of the chorion, which are part of the developing placenta, are going to begin to secrete HCG, and that's going to be necessary for the maintenance of the corpus luteum. Trophoblastic cells are going to differentiate into the cytotrophoblast, which is a mitotically active inner cell layer, and into the syncytiotrophoblast, which is not mitotically active, but the cells in the syncytiotrophoblast are multinucleate. So here you can see the syncytiotrophoblast and the cytotrophoblast. At 4.5 days, the cytotrophoblast is developing. At 9 days, the cytotrophoblast is present. The syncytiotrophoblast is developing. And then at 14 days, you can see the syncytio and cytotrophoblasts. And I don't expect you to remember this embryology. I just put this up to refresh in your mind what happens in relation to implantation. Now, the placenta develops from fetal and maternal tissue. And so this image just shows primary chorionic villi that are forming from the cytotrophoblast. This image shows secondary chorionic villi. They have a mesenchymal core surrounded by an inner layer of cytotrophoblast and an outer layer of syncytiotrophoblast, and then the chorionic villi vascularized from developing blood vessels in the connective tissue cores. So you can look at these primary chorionic villi that are formed by about 14 days after implantation, and then at 16 days after implantation, you're seeing the secondary chorionic villi. 21 days after implantation, you have well-defined tertiary chorionic villi. Here's a histological view of the amniotic surface of the placenta. It shows the chorionic plate and profiles of chorionic villi. Some of these chorionic villi, the larger ones, have blood vessels evident in them. The top insert shows the simple cuboidal epithelium of the amnion with underlying connective tissue. The bottom insert shows a cross-section of a villus that contain blood vessels, and the surface shows the syncytiotrophoblast. This image is the maternal side of the placenta, shows the stratum basale, that portion of the uterus to which some of the chorionic villi are attached. You can see stromal connective tissue, which is evident, and there are clusters of decidual cells shown in the insert on the bottom at higher magnification, and you can see various cross-sections of these chorionic villi. We have these slides here because in the laboratory we're going to ask you to distinguish between cytotrophoblastic cells and syncytiotrophoblastic cells. Here's a low power view of the placenta and then some higher power views of the chorionic villi. Note that cytotrophoblastic cells are usually seen deeper than cells of the syncytiotrophoblast. This just to remind you of what the mature placenta looks like. Note that oxygen-poor fetal blood enters the placenta through the umbilical arteries, and oxygen-rich blood is returned to the fetus through the umbilical vein. I'm not going to test you on this for our course, but these are things that I would expect you'll remember from your embryology. Let's spend the remainder of this podcast talking about the mammary glands. And as you know, mammary glands are a distinguishing character of all mammalian species. During embryonic development, breast tissue forms in both sexes. The glands develop along the mammary ridge in the embryos. For humans, usually one breast develops on each side of the mammary ridge. An extra breast, called polymastia, or an extra nipple, called polythelia, is an inheritable condition. You'll sometimes see that. Now, female and male mammary glands are histologically similar until puberty. In pubescent females, the mammary gland develops further under the influence of the sex hormones. The glands increase in size, primarily from the deposition of interlobular adipose tissue. The ducts extend and branch into an expanding connective tissue stroma. The ductal architecture of the mammary glands is completed as puberty ends and menstruation begins. The mammary glands are going to remain inactive until pregnancy, but then a pregnancy is going to stimulate the mammary glands to start becoming active. Estrogens and progesterones from the corpus luteum and later the placenta, prolactin from the anterior pituitary, and gonatocorticoids from the adrenal cortex all stimulate the inactive mammary gland and drive it to a more active state. At the end of pregnancy, the epithelial cells are going to be full of secretory vesicles, but milk production is going to be inhibited because there'll still be high levels of progesterone circulating. Milk secretion is going to begin at birth. It's induced by the release of prolactin, and ejection of milk from the breast is stimulated by oxytocin from the posterior pituitary, and it's also stimulated by the baby's suckling or nursing. Mammary glands are modified tubulo-alveolar apocrine sweat glands. There may be 15 to 20 lobes surrounded by connective tissue that are going to radiate from the nipple and branch into multiple lobules. The ductal epithelium is a stratified squamous, and it's actually keratinized at the nipple itself. Moving into the gland, it becomes a stratified squamous to a double cuboidal to a cuboidal or columnar through the remainder of the duct. Secretory cells in the active gland are cuboidal or columnar, and ducts and secretory units have associated myoepithelial cells. The connective tissue that surrounds the terminal ductules and the interlobular ducts, as well as the epithelial cells, are sensitive to hormones, and in an active mammary gland, it's difficult to distinguish the terminal ductules from the secretory units, and in fact, all the epithelial cells in the terminal ductules are actually differentiating into milk-producing alveoli. This just shows a histological view. This is an inactive gland. You can see these terminal ductules or acini. These would be not actively secreting at this point in time. This is a pretty picture, but it is done with a monoclonal antibody to proteins in the myoepithelial cells. So it's showing that the secretory alveoli in the mammary gland are surrounded by these myoepithelial cells. Here's an inactive mammary gland. You can see some adipocytes here, dense connective tissue, and you can just see these ducts. The arrows here point to lymphocytes. There are lots of lymphocytes associated with the mammary gland. Here are myoepithelial cells around the periphery of the ducts themselves. And there's also connective tissue around the periphery of these ducts. So compare this inactive mammary gland to the active mammary gland. Here again, it's difficult to distinguish the ductal cells from the secretory alveolar cells because in the active gland, the ductal cells are also actively secreting. The secretory alveolar cells here are shown at higher magnification, and here they're mostly cuboidal cells. Look at here, some nice plasma cells. You'd expect lots of plasma cells as you're going to be secreting a lot of IgA into the mammary secretions. And here's a nice profile of some myoepithelial cells, one here, some here, and again some of this connective tissue around the ductal units. Milk production involves both merocrine and apocrine secretion. So merocrine secretion is for the secretion of the protein components, and the milk apocrine secretion is for the fatty or lipid components. And the merocrine secretion is the mammary cells would be typical protein secretory cells, lots of rough-ER Golgi, material packaged into secretory vesicles, and then the apocrine secretion, you're just having pieces of the cytoplasm surrounded by plasma membrane pinching off with the high lipid content. Now, colostrum are the secretions from the mammary for the first several days after birth. That colostrum or pre-milk is alkaline. It has a higher relative protein and salt concentration compared to the milk secretion that occurs later. It is very rich in IgA. The high fat content milk has the same protein mix. It comes in several days later, and it will continue for as long as a baby continues to suckle or as long as the mom continues to nurse. And there's a phenomenon called lactational amenorrhea. It turns out that high levels of serum prolactin will be necessary for the mammary to continue milk secretion, and prolactin happens to suppress secretion of LH. So lactational amenorrhea, mothers who nurse for long periods of time are less likely to start their normal menstrual cycles until the babies are weaned.